Hello to everybody. Thank you for getting connected and listening to this interview at the Lymphoma Hub. I'm Emanuele Zucca. I'm the Deputy Head of Medical Oncology at the Institute of Oncology of Southern Switzerland in Bellinzona. And I'm going to discuss and to summarize the presentation I just made at the virtual EHA meeting on the role of chemo-free regimens in the treatment of indolent lymphomas, mainly of follicular lymphomas. As you know, in the last couple of decades, the outcome of follicular lymphoma has dramatically improved. And this is mainly due to the addition of the monoclonal antibody rituximab to a standard chemotherapy. The expected survival nowadays for follicular lymphoma patient is approaching, if not exceeding, 20 years. However, there is a subset, roughly 20% of patients, who would have an early progression and they still have a dismal outcome. Treatment of advanced indolent lymphoma, if they are not symptomatic, can be deferred until symptoms develop without affecting the overall survival. When treatment is needed, when the patient has symptoms or organ failures related to the lymphoma progression, standard treatment is today a combination of rituximab and chemotherapy. Rituximab alone has a very good activity in follicular lymphomas and mainly in any type of indolent lymphoma. And the remission rate is between 50 and 75% in most of the single agent studies. For this reason, about 20 years ago, the Swiss group for clinical oncology and in the same time the Nordic lymphoma group began to explore the role of rituximab alone in treatment of follicular lymphomas. And now we have a review the long-term data of both groups. So if I can show you this panel, you see the long-term data of SAC and Nordic lymphoma group studies of rituximab alone in follicular lymphomas. And you see that in both groups, the 10-year overall survival was around 78%. And this is exactly the same range, 80% more or less, of overall survival at 10 years observed in most clinical trials with immunochemotherapy, which means that starting with rituximab single agent is not jeopardizing the long-term outcome of the whole population, but there is at least 1/3 of patients who never need chemotherapy. And this is the important take-home message, the most important take-home message of my talk at the EHA. Then, having looked at this data, we start exploring why not to add other targeted agents to rituximab to improve treatment of indolent lymphoma in a chemotherapy-free patient. And us and other, we and other group show that a combination of rituximab and lenalidomide is a potentially good option for upfront treatment of follicular lymphoma. The second Nordic group study randomized R² versus rituximab alone and show an improvement in progression-free survival, but not yet, and probably we will never see an improvement in overall survival. So R² is a potential new option. There is also an important randomized study, the relevant study, which has shown that R² is leading to outcomes very similar to the one you can get with R plus chemotherapy, and however, with a pretty different safety profile. So there is room for future further study exploring the chemo-free concept, and according at least to our data, rituximab alone remains a sort of benchmark upon which to build the future chemotherapy-free regimens for indolent lymphomas. So thank you for your attention, and have a good day.